So, welcome to the mock interview today. It's acute myocardial infarction leading to cardiogenic shock and advanced management. That's the title, is it?
Okay.
Yeah, can you see that?
Yes, I'm seeing.
Okay, great. So, can you please read out the question, the statement, the stem?
Okay.
Yeah.
58 years old man present to emergency department, acute severe chest pain radiating to left arm and jaw associated with diaphoresis and nausea. The pain started 1 hour ago while at rest. He was history of hypertension, type 2 diabetic, and smoking. Initial
Great.
assessment, vital signs 90 over 50, heart rate 110, respiratory rate 22, saturation 94, ECG, ST segment elevation V1 to V4, labs, elevated cardiac enzyme, and normal liver function, renal function, blood sugar 180.
So, please go through the ECG so that we can begin with the questions then.
ECG is ST elevation V1 to V4, and
Yes.
I
Some
think
elevation in AVL too.
AV1 and AVL also.
Yes.
And
So 1 and AVL, yeah. And then 2, 3 and AVF, you have slight
ST
ST depression. Yes. So, okay. So, what is the diagnosis?
This is acute anteroseptal MI. Acute anteroseptal and lateral MI also. If I consider ST elevation 1 and L. Anterolateral MI.
So let's keep it at what kind of MI is it?
Type 1.
Type 1. And how do you say that it's type 1?
This is a blood thrombosis, yeah. Type
Okay,
1.
so it is thrombosis, it is total occlusion of the blood vessel. So it is ST elevation MI, right?
Yes.
Yeah. So the diagnosis you have made acute anterior wall myocardial infarction, specifically ST elevation MI. Okay. So what are you going to do next? What's the next step?
First, I will start with airway breathing circulation. Okay. And ABC.
Fine.
Second will resuscitation will go for will give antiplatelet and will activate.
Great. So what kind of antiplatelets?
I'll give aspirin.
Okay. So one is aspirin. So we classically give DAPT. What is DAPT?
DAPT.
So it's dual antiplatelet therapy.
Yes, dual antiplatelet therapy, yes.
Okay. So one of them has to be aspirin. So you have to load aspirin at the dose of 300 milligrams.
325. Oh, 3.
Okay. Yeah, minimum. So 325 in the countries which are available. So minimum is 300 milligrams. Plus you have to give one P2Y12 inhibitor. Okay. So right now the major guidelines are banking upon ticagrelor, but if we have to go by the classical system of working, it will be clopidogrel. How much?
300 I would give.
Wonderful. So 300 you will give. Anything else along with?
I'll give anti-lipids and analgesic also will give for him.
So we will give unfractionated heparin. Or we will give low molecular weight heparin. Okay. So we have to combine DAPT plus anticoagulation. So this is the step number 1, that you give DAPT plus anticoagulation. It can be unfractionated heparin or it can be low molecular weight heparin. And as you rightly said, for pain, you will have to give opioids, maybe morphine or tramadol if at all it is available. You can give oxygen support. What will be the oxygen requirement for a patient?
92.
Say again?
94 is okay, I think.
Yes. So you would like to keep oxygen support to keep the saturation above?
92, 94, 92, or 92.
So that is the international guidelines. That is 95% for a patient who has not been yet treated. Okay. So aspirin was given. Clopidogrel 300 milligrams was given. Nitroglycerin sublingual, if BP allows, unfractionated heparin or LMWX. Oxygen to support more than 95%, that is by the guidelines. IV morphine, and very important, this is a patient of ST elevation MI.
Yes, we will activate the BCI. Yeah.
So you will have to activate the cath lab. Yeah. What is the door to balloon time?
Door to balloon time, 1 hour.
So it is 90 minutes.
If available cath lab in the hospital, should be 1 hour. If not available, 90 minutes, yes?
So no. So it is 90 minutes if it is available in the hospital, and it is 120 minutes if it is not available.
Yes.
Okay.
Okay.
So basically in STEMI, we consider that it is important that time is muscle, and you have to act within this 90-minute time. You have to open up the blood vessel within 90 minutes. But before that, you need to do your homework. You have to give aspirin, clopidogrel, this heparin, anticoagulation, along with oxygen if the saturation is less than 95, and give IV morphine for pain relief, and definitely activate the cath lab. And as it is a case-based scenario, definitely there is a cath lab in the hospital. Okay. So this is what was done. Primary percutaneous intervention was done. What you see here is LED is 100% occluded. You can see that the LED is 100% occluded. And obviously, ECG also showed that. The patient was taken for a drug-eluting stent, and TIMI flow grade 3 was achieved. The patient was shifted back to the cardiac unit for ECG monitoring, serial troponin measurements, and to observe the patient for reperfusion injury and arrhythmias. Okay. Shortly after the arrival to the cardiac ICU, the patient develops hypotension, tachycardia, and signs of shock. Now the BP is down to 70/40. Heart rate is 130 beats per minute. The patient is cold and clammy, and you can see the JVP distended. Pulmonary edema is there on auscultation, and there are bilateral crepitations. Urine output is low. Bedside echocardiogram shows severely reduced LV function, around 25%. Anterior wall akinesia. What does this mean?
No cardiogenic shock.
No. What does this line mean? Severely reduced LV function, anterior wall akinesia. What does this mean? What does akinesia mean? Akinesia means infarction has occurred.
Yeah.
Because if infarction would not have occurred, then this patient would have hypokinesia. Solely because this patient has developed akinetic segment means the infarction has already occurred and this patient is going to give you a tough time. Swan-Ganz catheter was put. It showed low cardiac output, high pulmonary capillary wedge pressures, and elevated CVP consistent with cardiogenic shock. Yeah. So you rightly said, what is the diagnosis?
Cardiogenic shock, yes.
Cardiogenic shock, perfect. So the new add-on diagnosis is cardiogenic shock. So the complete diagnosis is STEMI anterior wall plus status post PCI, primary PCI, plus cardiogenic shock. Okay, fine. What will you do now? Patient's blood pressure is 70/40, heart rate is 130, patient is cold and clammy, JVP is rising, patient is unable to breathe, there is pulmonary edema, bilateral crepitations are there, and the urine output is decreasing.
First, so this again, go for ABC. I will for airway breathing. I will intubate the patient. I will also start inotropes for the patient. Vasopressor.
So you will intubate the patient, and this patient will crash because before intubation the blood pressure is 70/40. This patient is already running high on their own sympathomimetic drive. There is a lot of catecholamine surge already. If you are going to intubate this patient, wonderful. So you will put the patient on non-invasive ventilation. Almost all the randomized trials, they have proven that non-invasive ventilation is much superior to invasive intubated ventilation, because not only it decreases the work of breathing, it also helps
the preload and afterload.
Yes, to decrease the pulmonary edema. It decreases it shifts the volume from the pulmonary circulation to the systemic circulation. So this patient, by definition, has landed up in cardiogenic shock. The definition is systolic blood pressure less than 90, end organ hypoperfusion, proven by cold extremities, confusion, oliguria, less than 30 ml per hour urine output. This patient had only 10 ml per hour urine output. Lactates, although were not given, there are chances that the lactates would be given if the ABG was provided to us. Cardiac index less than 2.2. Now you can define the cardiac failure or acute cardiogenic shock by biventricular nature, LV predominant nature, RV predominant nature, and also by non-congested cardiorenal, cardiometabolic, which are a chronic state of heart failure. Identifying the cause of cardiogenic shock is very important. As you can see here, number one reason is acute myocardial infarction, as in our case. Other causes are patients who have suffered a cardiac arrest, who have had arrhythmias like ventricular or supraventricular, conduction disorders like complete heart block, Venke backing, infectious diseases like myocarditis, iatrogenesis like during procedure, if there is a coronary artery dissection, the patient can develop cardiogenic shock, and of course, non-compliance with the treatment. The investigations to arrive at the diagnosis includes 12-lead ECG and X-ray. X-ray, what will you see on the X-ray?
The bilateral infiltration, the pulmonary edema.
Okay, so curly B lines.
Yes.
You will see pulmonary edema. Okay. Laboratory tests. In laboratory tests, what you will see is in ABG, you will have hypoxia.
Yes.
The pH may be acidotic. Lactates will be increased. And of course, transthoracic or, if at all, transesophageal echocardiography, lung and pleural ultrasound. Of course, for ruling out other causes, you can do CT scan. The moment patients is in cardiogenic shock, you will need more monitoring. You will like to put central venous lines, you would like to put arterial lines, you would like to put a pulmonary capillary wedge pressure monitoring device, that is thermodilution catheter. So this is how you will manage and diagnose and manage the patient of a cardiogenic shock. So what did we do here? Because this patient's blood pressure was low, the patient was cold and clammy, the urine output was decreasing, the patient was having pulmonary edema. This patient was started on inotropic support with dobutamine to improve the cardiac output, along with norepinephrine infusion to maintain the mean arterial blood pressure above 65 millimeters of mercury. So you need to have these patients on inodilators or on inoconstrictors, depending on the blood pressure of the patient. So if the blood pressure is low, you would like to go for inoconstrictors like have a dobutamine, which is an inodilator, along with norepinephrine to maintain the blood pressure. Plus, you will need diuretic support immediately to get rid of the pulmonary edema. Plus, you will need this patient to be put on NIV, okay, non-invasive ventilator. Along with that, the patient was put on an invasive arterial line for continuous blood pressure monitoring. A Swan-Ganz catheter was put to measure the cardiac output and the preload. So this is the standard management that you will have to reply to in the Viva when the questions are asked. So you need to do what? Etiological therapy. That means you will do a PCI. You already done that. Optimizing the hemodynamics by improving tissue perfusion. You can do by using loop diuretics. Sorry. If the urine output is not there, you can initiate renal replacement therapy. If the blood pressure is low, add the norepinephrine, which is vasopressor of choice, along with try to find if there are any other causes of vasoplegia like sepsis. Now, this was step to improve the tissue perfusion. To improve pump function, what will you do? You will define which area of the heart is involved. If it is the RV which is dysfunctional, you will increase the preload, you will increase the volume expansion, you will decrease the wall pressure so that the filling pressures are increased. If the RV has increased after load, like there is left ventricular failure along with, then you will improve the LV function and decrease intrathoracic pressures. Now, if it is a left ventricular failure, like in our patient, if the LV filling is inadequate, of course, we would like to fill it up, but this is not the case in our patient. Our patient has an increased LV after load. So we will perform a vasodilatation and reduce the obstruction and give them dobutamine. Managing the organ dysfunction is via the help with oxygenation. How do we do that? Non-invasive or invasive mechanical ventilation, preferably non-invasive. Reducing their metabolic needs by giving them sedation, by managing acidosis, by managing overload control, by using renal replacement therapy. If it is a cardiogenic shock, but if it progresses, then we will have to take another action. Okay. So what did we do when the patient landed up in cardiogenic shock? We started the patient on norepinephrine and dobutamine infusions. We put the patient on NIV support, and then we will be waiting for the patient to improve. But on the other hand, the patient actually, despite these inotropic and vasopressor therapies, the patient still remains hypotensive. The BP is 80/50 with worsening end organ perfusion. The oliguria is worsening, the lactates are rising. The patient is becoming tachypnic. The patient is persistently tachypnic despite being on NIV. The patient is still cold, clammy. The pulse rate is 140 per minute. The patient is not settling. The patient is not settling. What are you going to do next? What is this?
First, I will go for
yes. Okay.
For intubate the patient.
Hmm.
Second, I will arrange for mechanical device to help decrease the post.
Okay. What mechanical devices are there to help unload the left ventricle?
We can start with the intra-aortic balloon pump.
Okay,
Or
so first option is IABP. Yes,
ECMO.
next.
We can use ECMO.
What kind of an ECMO?
VA ECMO.
VA ECMO, okay. Anything else?
We can use umbrella.
Okay, we can use Impella. Okay. So, yeah.
If the oliguric or patient oliguric, will set him also for, I don't know, is now or after we'll start the CRRT.
Okay, fine. So, the new add-on diagnosis is refractory cardiogenic shock. So, we have a patient who has STEMI anterior wall. So, the diagnosis keeps on changing. That is how you orient your mind to take the right decision. Anterior wall STEMI with refractory cardiogenic shock. Status post PCI. Okay. So what next? You've already replied to that. So what are the therapies for refractory? So how do you define therapy refractory cardiogenic shock? When optimal fluid has been given, inotrope pressure management has been done, but there is persistent hypotension, there is persistent high lactate, there is low SVO2, the end organ hypoperfusion is there, or these patients have received an active CPR or pharmacological resuscitation, that is inotropes. If this patient did not require active CPR or pharmacological resuscitation, then you immediately screen these patients for advancing age, presence of active malignancy, presence of severe COPD, chronic dialysis, septicemia, other non-cardiac life-limiting diseases, cachexia, frailty, poor health compliance. If any of these are not present, then you have the options of going for ECMO and implantable LVAD ASAP or within 24 hours. However, if these patients have these things, then you should consider palliative care as the only option. So in our case, the patient is a young 54-year-old male. He only has diabetes, and there are no other criteria to remove this patient from the need of a mechanical support device. So we put the patient on VA ECMO. And because this patient was unresponsive to the medical therapy, we put the patient on VA ECMO as a temporary circulatory support. But you remember the echocardiography of this patient? What did this patient have? Ejection fraction of 25% with akinesia. So that means there are chances that this patient may not recover. Let's see if the patient improved. This patient was taken for femoral arterial and femoral venous peripheral VA ECMO. Flow settings were adjusted to maintain cardiac output, oxygenation, and perfusion. The goals were to provide cardiac and respiratory support while unloading the LV. This is important to understand. And either it facilitates recovery or provides as a bridge to further intervention. Now the 48 hours have gone by on the VA ECMO. The patient shows no significant improvement in myocardial function. Obviously, we know the patient's EF was 25% with akinetic LED segment. So this patient was always thought of not improving on VA ECMO. What is to be done next? We need a more permanent mechanical support. So what is the next permanent medical support? Mechanical? It is LVAD. Of course, Impella and all are available, which are types of LVAD only. Now, these are a bridge to decision. So LVAD placement, we understand that it is a bridge to recovery or bridge to transplantation. LVAD implantation helps to unload the left ventricle and improve the systemic perfusion. What do you need to check in the patients who have been put LVAD? you monitor for right heart failure. Why does right heart failure occur in these patients? Any idea?
No.
Okay. So this is LVAD. It is basically pumping the blood into aorta, right?
Yeah.
So now the thing is that this LVAD is not a pump device. This is not a pump device. It's basically a motor.
All
right. So the right ventricle is still in a pulsating phase. So this will be pulsing out blood into the pulmonary circulation, but the LVAD which is placed in the left ventricle is actually only a motor. It's running like this. So there will be congestion in the pulmonary circulation, and of course, some congestion will always be there. And gradually, the right heart failure may start, leading to ascites, pleural effusion, ascites, and peripheral edema. And of course, you need to look for arrhythmias and bleeding complications, because these patient needs to be not only on antiplatelets but also anticoagulated. You need to ensure optimal anticoagulation to prevent the pump thrombosis. In rare cases, the patient may require right-sided VAD, ventricular assist device, also to support the right ventricle. Is that clear till now? These are the questions that you'll be asked very commonly. Okay. Now this patient is put on LVAD and you are monitoring this patient for right heart failure arrhythmia. What other complications can happen? Okay, what complications can happen on ECMO?
ECMO for left ventricle strain or north-south syndrome, Harlequin, or bleeding. What else? Dissection, infection.
Okay. So basically, we can divide these things. We can divide these things like for VA ECMO, the complications can be divided on bleeding and coagulation issues. If you categorize them, it will become easier for you to remember. So these are the major complications. Why? Because anticoagulation therapy will be required at all the times. So bleeding can occur at the cannulation sites, into the GIT, into the lungs, and the patient also have a risk of ICH, intracerebral hemorrhage. Of course, along with bleeding complications as a major bleeding complication, other complications can be heparin-induced thrombocytopenia. Because these patients require anticoagulation at all times, there are chances that these patients can develop a heparin-induced thrombocytopenia and in fact develop a DVT. So they are more of a thrombotic complications. Then of course they can develop DIC. Okay, these are the bleeding complications. Then comes the thromboembolism, then comes the cardiac complications. So second set of complications are cardiac complications. What cardiac complications can occur on a VA ECMO? Any idea?
Left ventricle strain, or
why?
After improve the contractility, this one will happen, yes.
So where is the cannula put? You have to understand that in our case, we put the cannula in the femoral artery, right? So this is the heart and this is the aorta. It's going out. And in the aorta, we've put the cannula here in the femoral artery. All right?
Yeah.
So whatever cardiac output is coming from this aorta, we have put another set of cardiac output into the femoral artery. Isn't that? So what have we done is we have increased the resistance to this flow. So we have increased the systemic vascular resistance. That means we have increased the afterload.
afterload and left. Oh.
Okay, so the left ventricular afterload increases after the VA ECMO. So there is increase in the left ventricular afterload. So you need to adjust the flows of the VA ECMO to such an extent that it does not interfere with the cardiac output, the native cardiac output. Is that okay?
Aye.
All right. Another thing that can happen is cardiac complications is aortic. Because of the increasing afterload, there can happen is aortic thrombosis. Okay. The blood can clot here because of the stasis. It can clot here, leading to aortic thrombosis. Also, it can lead to limb loss. Why? Because the confluence point where we introduce the femoral cannula, the distal circulation to the leg is gone. That is why we need a side cannula, isn't it? To perfuse the distal site. So these were the cardiac complications. Third is the infections. So infections, of course, there can be nosocomial infections or there can be cannula site infections. So if you remember this way, it will become easier for you to tell them in the answers. Is that okay? Okay. Fourth are neurological complications. So neurological complications basically can lead to stroke, intracranial hemorrhages, or even hypoxic brain injury because of the decreased cardiac output and the time taken for this thing. Fifth is vascular complications. So vascular injuries, aneurysm formations, and distal limb infarction. So distal limb ischemia. So it can lead to compartment syndrome. And of course, aortic dissection can occur. Renal complications like AKI can occur, pulmonary edema can occur, VAP can occur, pump failure, oxygenation, all of them can occur. And as you rightly said, last but not the least is the Harlequin syndrome, where if we look at the patient like this, then 50% of the body will be well perfused and 50% will be not perfused. So this is this is Harlequin syndrome. So these are the complications. So can you again recite them for me? The complications of ECMO.
First, the cardiac increase after load.
You start with bleeding, okay?
Bleeding, thrombosis, the hit the EDIC.
Yeah. Second,
cardio increase after load.
Okay.
And third, infection.
Okay.
Neuro.
Wonderful.
Hypoxic or poor perfusion, and the last one, nephro or.
Okay, wonderful. So these were the complications for VA ECMO. Now tell me the complications for LVAD.
We'll go for bleeding, thrombosis.
Wonderful. So the first option will
infection.
always be bleeding plus thrombosis.
And right ventricle.
Okay, so we have a pump now in the site. So pump thrombosis is another thing. If the patient is not on adequate anticoagulation, pump thrombosis and pump embolization. Sometimes pumps parts can embolize, leading to stroke, leading to acute renal shutdown. Okay. And then there is a drive line. There is a drive line. So drive line is power cord. So if this is the device, there is a power cord which is outside the body. Okay. So power cord. So this drive line infection can occur, leading to sepsis. Okay. So bleeding, pump thrombosis, pump part embolization, leading to stroke and acute renal shutdown or mesenteric ischemia, then drive line complications, including sepsis, and then right heart failure. Fourth is right heart failure. Okay. Fifth is arrhythmias, atrial or ventricular. A pump device does not ensure that the patient will not have arrhythmias. And of course, along with that, there is a bigger complication known as hemolysis, because there is a pump device inside. So this will lead to hemolysis. And of course, renal failures. The last but not the least is device malfunction. Although these are very expensive devices, close to 1 CR in Indian rupee. So device failure is another problem. So we have to understand that it can either be a pump failure or battery failure or cable or driveline injuries that can lead to this problem. Okay.
Okay.
So, yeah. So let's go back. These are the questions that will be asked. What are the complications for VA ECMO? We've done that pretty well. And then the complications of this. So pump thrombosis is a big complication. Regular anticoagulation for INR to be kept around 2.5 to 3.5. Then these patients can have bleeding tendencies. Infections are important. Meticulous care of the driveline exit site to prevent the infection is important. All right. So my dear friend, we have put our patient on an LVAD, but this patient again develops chest pain and ECG shows ST segment elevation in anterior leads again. Okay, I'll jump on to the diagnosis. This patient has now developed
stent thrombosis, yeah.
Stent thrombosis, because we were forgetting that we have put the patient on a drug-eluting stent. So what is the next step? How will you manage stent thrombosis?
Again.
So take the patient to cath lab and then open up the vessel. Okay. So this patient was kept on clopidogrel post PCI, and the patient has developed a stent thrombosis on clopidogrel. What will you do now? Aspirin plus so you will put the patient on aspirin plus ticagrelor. Okay. So repeat coronary angiogram confirms the patient with instant thrombosis. Thrombus aspiration and repeat balloon angioplasty was done. DAPT was changed to ticagrelor plus aspirin, and we can also give 2B3A inhibition in these cases. So what is the conclusion? So the patient eventually survived. So after a prolonged support on VA ECMO, the patient gradually stabilized with improving LV function. He was successfully weaned off ECMO, but continues to be on LVAD and remains on dual antiplatelet therapy. So this case emphasizes the comprehensive management of the patient with acute MI, progressing through all the stages of cardiogenic shock, role of mechanical circulatory support, and handling of complications such as stent thrombosis. Have you got the case?
Right.
So this was the case for the CCS. Now we will take you to the CBS. Okay, so I have few images for you, and you just tell me what is the diagnosis and how to proceed. Okay, these are, okay. So this is a patient. This is a patient, a 45-year-old man who came to the hospital with acute anterior wall ST elevation MI. And the patient was taken up for a primary PCI. But on day 2, patient developed sudden onset breathlessness. Echo was done, and this is what you see. Question number 1. what is the diagnosis? Question number 2, how will you manage it?
That's actually,
Yes. What do you see here?
After 2 days, this is rupture. And you mean I did not see actually that.
Do you see the picture here? Do you see the picture?
I'm seeing, but not clear actually for me. And what is?
Oh, is it?
Okay.
This basically there is acute mitral regurgitation here. Can you appreciate that?
Yes.
Yeah. Yes.
I will go for.
Yeah.
This is papillary muscle rupture for our mitral gear, the wing.
Okay. So this could be, yeah, true. This could be acute papillary necrosis, or it can be ischemic MR. So what will you do? How to manage acute mitral regurgitation?
We will ask for surgeon opinion, and we'll put in this time an intra-aortic balloon pump. Yes?
Yes. So number 1, again, you will manage the ABC.
All
right. So you will manage the ABC. You will need an pulmonary artery catheter in this patient. So what you see here is, this is the left ventricle, this is the left atrium, this is the jet is acute mitral regurgitation. So this is post-MI acute mitral regurgitation. How will you manage it? Definitely, first is ABC, second is NIV, third is diuretics, fourth is intra-aortic balloon pump, and you will give this patient vasodilators. So nowadays, ARNI. What is ARNI? What is ARNI? Okay. So this is angiotensin receptor and neprilysin inhibitor. So Vimada is the brand name. So valsartan sacubitril combination. Okay. So vasodilators, you can use ARNI, you can use nitrates. Nitrates will help in decreasing the preload and afterload. Okay. And you can use dobutamine in this patient because it is a inodilator. So it will decrease the afterload, and hence this patient will get benefit from the flow into the aorta. So mitral flow will be decreased. And of course, if nothing works, then third is CTVS, that is surgeon's opinion. All right. So can you tell me again? You can read from the screen in case. So this is post-MI acute MR. How do you treat it?
ABC and vasoventilation, diuretics, intra-aortic balloon pump, and vasodilators. This one, angiotensin receptor, marine. And this is you mean valsartan, and this is the one, or
say again?
The RNI. This is the name of ARBs, like valsartan and.
Yeah, valsartan and sacubitril combination.
Yes.
Yeah. So you will use nitrates, you will use dobutamine, and you will refer the patient for a CTVS consultation. Okay?
Yeah.
Cool. All right. This is a patient who came to you with complete heart block, and the patient was given a temporary pacemaker in the emergency. You can see the temporary pacemaker wire shining bright. So after some hours, the patient became hypotensive. The patient was taken up for a CT to rule out coronary this aortic dissection, but instead you found out something here. So what is it? Any idea? What do you see? What do you see? So this is the temporary pacemaker shining bright.
Yeah.
This is the temporary pacemaker shining bright. This is the LV. This is the RV. And what is this?
You mean the pericardial effusion, or
what is this? Yeah. What is this? So what has happened? Because we need to give a diagnosis, right? Because I would ask, number one, what is the diagnosis?
Iatrogenic pericardial effusion, like that, from the leads. I don't know. I don't see this.
You have not seen. Okay, fine, no problems. So I will show you an X-ray also for the same. Second is management. So I'll show you the X-ray. Yeah. So you see this X-ray?
Yes.
What do you see? So this is right ventricular. Yes, this is right ventricular perforation leading to pericardial effusion. Okay.
Iatrogenic.
Iatrogenic. So how are you going to manage it?
I will manage it. We can do pericardiosynthesis, or change pull the lead. I don't.
If you pull the lead, this patient will die, because this patient, now the rent is closed, but then the rent will be open. So you will do serial echocardiograms to see if the pericardial effusion is increasing, leading to tamponade. So you don't want the tamponade to happen. In case tamponade happens, all you need to do is put in a pigtail catheter in the pericardial space. Okay. So that will be, as you said, pericardiocentesis. And if the patient is still not improving, then you, of course, you discuss the case with the CTVS team to get the surgical correction done. Okay. Hello.
Yes, I'm.
So the number one is to do serial echocardiograms.
Yes.
To rule out cardiac tamponade. And if tamponade does occur, you will do pericardiocentesis. It should ideally stop on its own, because right ventricle doesn't have enough muscle on it. So it usually stops and heals, but eventually you will need a CTVS team to look into the matter. Is that okay?
Yes, sir.
This is a very, very interesting patient. Actually, this happened in our own hospital. So this is how I have these images with me. So this is RV perforation secondary to a temporary pacemaker. All right. Okay, this is a young guy who was found unconscious on the road and was brought to the emergency, and the ECG was done. This is the ECG. What is the diagnosis? How do you manage it?
Osborne wave, hypothermia.
Very good. So this is the Osborne wave, okay?
Yeah.
Yeah. So this is Osborne wave. So how do you manage it?
Why what invasive or non-invasive, or what heat like blanket first, and we can use the fluid high temperature 40. We can, if not respond, we can extracorporeal also, we can use it the final.
Okay. So step number 1, classify the degree of hypothermia, whether it is mild, moderate, or severe. Okay. So number 1 is this, that you need to diagnose it. If it is 32 to 35 degrees, it is mild. If it is 28 to 32, then it is moderate. And if it is less than 28 degrees, it is severe. Then this is the number 1 step. Step number 2 is rewarming. Now, the rewarming is where you are required. So number 1, it is either passive external rewarming. It has to be gradual and slow. Is that okay? Passive external rewarming for mild hypothermia. Active external rewarming, it is done for moderate hypothermia. How? As you said, warming blankets, warm IV fluid, heating pads. Okay. Then is active core warming. Active core warming is done in cases of severe hypothermia. How do you do that? You give them warmed IV fluids at a temperature of 38 to 42 degrees centigrade. Warmed oxygen you give to these patients. And then you can do peritoneal dialysis or lavage with hot water, warm water. And then, of course, 4th is extracorporeal warming. Okay?
Okay.
So rewarming has to be done based on the degree of hypothermia. So you have to classify the hypothermia first. If it is mild, moderate, or severe. If it is mild, all you do is passive external heating. That is done by just covering the patient with warm blankets, placing them in a warm environment. If it is 28 to 32 moderate hypothermia, then you have to do external active rewarming. That is done with the help of electrical devices. Third is active core warming, done in the cases of severe hypothermia with warmed IV fluids, warmed oxygen, and of course peritoneal lavage. And then it is extracorporeal warming. Okay. So this is Osborne's wave. You exactly identified it. J wave or Osborne wave, it is known as. And you can see that this wave is pretty much there in the. Can you? So far, so good?
Okay.
Great. All right. Okay. Now tell me, this is a young man. He was playing cricket and he felt dizzy. So he was rushed to the hospital, and this is what you see in the ECG.
This is atrial fibrillation.
Wonderful. So how do you manage it?
If hemodynamic is stable or unstable, if unstable, we can give him synchronize, if cardio synchronize cardioversion. If stable, we can give him medical therapy.
Okay. So what are the medical therapies that we have? Do we do rate control or rhythm control?
Beta blocker we can give, or can
so yeah. So basically, there are two approaches. One is rate control and the other is rhythm control. So all we need to do is in elderlies with dilated hearts, it is good to just give them a rate control. But in young people with paroxysmal atrial fibrillation, it is always wise and advisable to bring them to a normal sinus rhythm. So, you give them beta blockers, you give them these calcium channel blockers, and of course, digoxin. All of them can help bringing them to a rate less than 110. But for rhythm control, you need to give them pharmacological cardioversion, that is amiodarone and flecainide. So worldwide, flecainide and amiodarone, they are used to do this. So much so that people who have recurrent episodes of atrial fibrillation, there is a pill in the pocket approach that uses flecainide. Okay. How about anticoagulating these patients?
If is recent, less than 2 days, no need coagulation before you give him.
So this was a young male, 30 years old, went to play cricket, no comorbidities. Do we need to anticoagulate this patient?
No, I don't.
Okay, so this patient does not require any anticoagulation. Okay, this is a patient, 40 years old, came driving to the hospital because he was feeling uneasy and he has had gastroenteritis and loose stools vomitings for last 4 days. He was at home, but he started feeling dizzy and he has uneasiness in the chest. So he rushed to the hospital. When he came out of his car, he crashed on the floor. This is the ECG that we did. What is this? What biochemical abnormality can be there with this ECG?
Hyperkalemia, this one will come with
yes. So this is hyperkalemia. So what is the immediate treatment?
Immediate treatment will give him first calcium stabilize the membrane, then we'll give him glucose, insulin, and we can give bicarb, and we can give.
So immediate is calcium gluconate, because calcium gluconate will try to reverse the ECG changes. So it is a pharmacological antidote for hyperkalemia. Immediately when you give calcium, the patient reverts back to
sinus.
Yes, to the sinus rhythm. Let me see if I have. Okay. So this is after calcium. Can you see how fast it happened? So this is hyperkalemia before calcium. This is hyperkalemia after calcium. Okay?
Yes.
All right. Well picked. Very nice. So this is typical ECG appearance. Mild, moderate, severe hyperkalemia. This is how you see the widening of the QRS complex that happens. Nevertheless, the treatment, the first line treatment is, how do you manage is IV calcium gluconate. Okay? Immediately. All right. So we have a 22-year-old male presenting to the emergency department after a high-speed motor vehicle accident. He was in the passenger seat and was wearing a seat belt. The patient reports chest pain with breathing difficulty. Vitals are 135/95 blood pressure and pulse of 105. On physical exam, the patient is stable with a seatbelt imprint on the skin of his chest. An anterior-posterior radiograph demonstrates an obscured aortic knob. CT is done. This is what you see. What has happened here?
Aortic injury, aortic rupture.
So how do you treat it? How do you manage it? This is what has happened.
And
so there is a pseudoaneurysm in the aortic arch. How do you manage?
I will manage as ABC, then I will ask urgent surgery, vascular surgery.
So you will manage this patient with ABC and then resuscitate the patient. and eventually give. How about therapeutic hypotension?
Decrease the blood pressure around 100
Yes.
and the rate around 60, then we'll arrange for surgery. This is the and pain, of course.
Wonderful. So they can put a stent also, they can put a surgery also, depending on the kind of injury. Okay.
Then, yeah, they can put stent in the arterial, this one, yes. Sorry, stenting.
This one. This is basically the arch of aorta is involved.
Arch.
Yeah. So they might need an arch repair, and in that case, they might need a Bentall to be done if the valve is also injured. Okay.
Okay.
So CT angiogram is to be done immediately, and then of course endovascular repair can be done if the system has it, and if the endovascular repair system is not available, that is TVAR, then of course you will need a open surgical repair. All right, so this is a young patient who was also riding a motorbike. He met with an accident, and when he came to the hospital, he was breathless, and you did a chest x-ray, and this is what you find. And then in the CT chest, this is what you find. This is the chest x-ray. This is the chest x-ray. This is the CT chest. What is the diagnosis and how will you manage it? So this is a traumatic lung contusion. Okay. You see here and you see here. So this is a traumatic lung contusion. Are you there?
Yes. What do you want?
Okay. So this is traumatic lung contusion. So how will you manage this patient? What kind of injury is this classified as? This patient is on ventilator. He's unconscious. He is intubated already. He's on ventilator. And this is what you find. So this patient has a traumatic lung injury and you treat it like ARDS. So what do? You use low tidal volume ventilation, permissive hypercapnia. You give PEEP. And then, of course, gradually you monitor this patient with ABG and serial imaging. And eventually, as the lung contusion settles, you try to wean off these patients. A far-reaching idea is that if this patient does not manage saturation even on the maximal ventilation, then you will need a VA ECMO for this patient. Okay? Yeah. Okay, this patient, can you see what it is? What image is this?
Ultrasound IVC.
Wonderful. So this is IVC ultrasound. This is a patient who came to the hospital after falling from height, and the patient had a cut injury on his arm, so he had bled a lot. The patient was given 3 units of blood, and the patient developed pulmonary complications. Patient went into pulmonary edema, required NIV, and once the patient was put on NIV, the patient developed oliguria. The urine output dropped. So eventually, to see the volume status, the patient was taken up for an ultrasound of the IVC. These are the 2 images that you get. What is the diagnosis and what is the management?
I think is need fluid. The patient still collapsibility is.
Yes. More. So this is a collapsed IVC. This patient needs fluid boluses. So what is a fluid bolus by definition?
What mean fluid bolus by definition?
Yeah, how much is the fluid bolus by definition?
400, 350, 400, yes.
350 to 400
over 15 minutes.
Yes. So what is that process known as? This is known as fluid responsiveness.
Yes, fluid responsiveness.
Yeah. So if the patient is fluid responsive and the IVC collapse is there, you keep on giving fluids until the patient either has features of fluid overload or the patient has an IVC which is stopped collapsing.
Yeah.
Okay. All right. So this is a patient. Yeah. This is a patient who's on IABP. Yeah. The patient is having this picture on the IABP. So what is the problem?
This is late inflation.
This is late inflation. So what is happening here is that the patient's diastolic
augmentation same
is the same as unassisted.
Yes. Yeah. Suboptimal coronary perfusion will be.
There will be suboptimal coronary perfusion, and in fact, the patient's afterload will be increased. Yeah. So all you need to do is readjust the inflation. You have to make a little earlier inflation. Yeah. Okay. So that takes care of the CBS also. So this was the last question. Okay, no, this was not this is the last question. This is a 30-year-old lady who just had a delivery of a full gravida, full term baby. After delivery, sometime 30 minutes later, she developed breathlessness and she collapsed. Patient was intubated and immediately an echo was done, and this is what you see. So what is the diagnosis and what is the management?
Dilate the right atrium also. This is amniotic embolism, and the diagnosis.
This could be anything. This could be amniotic embolism also. This could be pulmonary embolism also. So this is a pulmonary embolism by definition.
Pulmonary embolism, yes.
Yes. So how do you say that this is a pulmonary embolism?
This is dilated right ventricle and atrium.
Yes. So the RA, RV both are dilated. So because they are dilated, yeah. So this is the right ventricle, this is the right atrium, and both of them are dilated. So this is pulmonary embolism. So the patient is already, because the patient crashed, so you intubated the patient is on ventilator, and you can, if you take this patient for this patient is dying, so what will you do immediately?
Thrombolysis, okay. Or mechanical embolectomy or thrombolysis.
Okay, so the thing is that you have to differentiate between pulmonary thromboembolism and amniotic fluid embolism. So the thing is, if the patient has pulmonary thromboembolism, yes, thrombolysis is the thing that you need to do. But if it is an amniotic fluid embolism, that probably this patient requires VA. Okay? Because this patient otherwise will not survive. There is hardly any circulation happening into the, or maybe VV ECMO can also help if you can just support the circulation for some time. So this is what it is. This patient has embolism, either pulmonary thromboembolism or amniotic fluid embolism, but the management will change based on the diagnosis. So you can, there is no time to do a pulmonary CT pulmonary angiogram. This is basically echocardiography findings in cases of acute pulmonary embolism and chronic pulmonary embolism. And you can see that RA-RV dilatation is a dictum. So that's it. I hope it was worth it.
Thank you. Thank you.
I've tried to make it interesting. Stop sharing. Yes. I hope it was interesting for you. I think we covered almost all the topics that were required in the cardiology segment. And if there is anything else you need, you can discuss with me right now.
Thank you. Thank you.
All right. Okay, Dr. Ziad.
Thank you.
Yeah,
Yes.
take care.